A very good evening to all. I am Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, ma'am needs no introduction at our platform, but yet it's our great pleasure and honor to introduce her. She is none other than the very renowned gynecologist, Dr. Bharti Kalra, ma'am. Ma'am is MD in Gynae, consultant at Bharti Hospital, Karnal. With ma'am wonderful insights, we are going to talk about the topic for today, which is PCOS, what a physician should know. Before moving on to today's topic, let us have a brief look on what the topic says. So, polycystic ovary syndrome is one of the most common endocrine disorders affecting women of reproductive age. However, its complexity requires a multidisciplinary approach to diagnosis and management. To enhance our clinical practice and to improve the outcomes for women with PCOS, we have all joined together today on this platform to know more about it from Dr. Bharati Kalra, ma'am. So now, without any further delay, I would like to request ma'am to take over from here. Ma'am, over to you.
Thank you. Good evening, dear friends. As Batul has already told, that this is a very vast topic to be attended by all branches of our medical branches, and even the dietitians and exercise specialists. Everyone should know about PCOS and its management. So, in and day out, we come to know about the term PCOS, or some girls call it as PCOS. So, what does it actually mean? What is the underlying problem? This is a common multifactorial hormonal disorder affecting the reproductive age woman, characterized by hyperandrogenism. Ovulatory dysfunction means there are anovulatory cycles, and if we go for ultrasound, we find polycystic ovaries. And this is the major cause of anovulatory infertility in today's scenario. So, if we need to diagnose it, can we diagnose it in adolescents? Yes. After 1 year of attaining menarche, we can diagnose it if someone is coming to us with the complaint of irregular delayed menstrual cycles. One third of patient might be having regular cycles, regular monthly cycles, and someone might be having short cycles. And along with this, she is getting unwanted hair growth on her face or very severe acne. As we know, the acne are common at puberty, but if these are severe, or the girls who have unwanted hair growth, rapidly increasing hair growth, in those cases we should suspect, in those adolescents we should suspect this PCOS condition. And usually our HP axis, hypothalamo pituitary axis, takes 1 to 2 years for maturation. So that is why we consider PCOS after roughly 2 years of menarche. But in some cases, we suspect it. Even if they are not fulfilling the criteria, we keep them with suspicion that this girl might develop into PCOS. As far as the later age or adult women are concerned, there is fixed criteria. If there is features of androgen excess or ovulatory dysfunction, or if we get ultrasound, we find polycystic ovaries. Remember, ultrasound is important for the adult woman, but it is not included in the criteria for adolescents, because in during adolescence there are multicystic ovaries. Because of sudden surge of hormones, the ovaries become multicystic, but these are not polycystic, means these don't have thickened stroma as seen on ultrasound. So we know PCOS is a risk factor for metabolic syndrome. As this is topic is mainly for physicians for today's seminar, so physicians see metabolic syndrome patients day in and day out. But if they consider that underlying cause may be polycystic ovaries, then they are able to attend it in a better way and to address all the issues affecting the woman's life. PCOS is the mother of all non-communicable diseases. That is why its timely diagnosis, early treatment are mandatory. But remember to avoid overdiagnosis. At times, patients come with the ultrasound report of PCOS and we look for other features. She is getting regular cycles and she doesn't have any feature of hyperandrogenism. In those cases, we suspect that whether this diagnosis is correct or not. So, if we label someone at a younger age with the PCOS and she lives with that label throughout her life, if it is not there, we should try to avoid labeling it. PCOS can present at any age, with wide variety of symptoms. Sometimes at puberty or in unmarried stage, young age, it might be asymptomatic because patient is maintaining weight, she is following a healthy lifestyle, but once she gets married or she enjoys the other food items or she stops doing exercises after marriage or something as about in her day-to-day activities, sometimes they join these high-profile sitting jobs and they reduce their physical activity as well as the exercise. In those cases, the symptoms may manifest. In the cases of sudden weight gains, the symptoms manifest. So, underlying crux of management is lifestyle modification and weight optimization because obesity and PCOS usually go hand in hand. So that is why we say the octopus of ovarian syndrome. So how should we approach it on a person-centered base? There are 8 M's. Like its mirror-related symptoms may be there, just like acne, hirsutism, acanthosis, or menstrual symptoms, or maternal, maybe inability to conceive, or recurrent miscarriages, or pregnancy outcome is not optimal. Mood related changes. She might be obese and leading a depressed life. She doesn't want to, maybe because of her mirror features, means she is hirsute. That is why her mood is depressed. So, all things are interrelated. And she might be having metabolic dysfunction, other medical causes, just like associated diabetes and other hormonal diseases. Or later on, she might be having some mitogenic potential, means endometrial hyperplasia, and might be having endometrial carcinoma. So we should suspect all these conditions, and she might be having monetary issues. We advise her medicines which are not affordable to her. So, irregular or no periods, difficulty in getting pregnant, depression, anxiety, economic burden, medical conditions, dermatological features. So, all these things affect her life. It might be affecting her self esteem. So, she is not socially active and she is not going because of her body image, she is not attending social functions and not willing to go into sexual relationship. So, this is affecting, this manifestations affect her life throughout. So, what could be the causes? The underlying feature is hyperandrogenism and associated insulin resistance. So, which may manifest as visceral adiposity. That is why it is obesity as well as PCOS go hand in hand, and the hormonal imbalance like rise in AMH, which is leading to ovulatory dysfunction. So all these are the causes. I'm not going into details of this. So just going to PCOS, how it may present to the physicians. May present with the adiposity or hypertension, dyslipidemia, dysglycemia, or diabetes. So physicians should be aware if someone is having PCOS, so they should rule out all other medical conditions, including non-alcoholic fatty liver disease and depression and anxiety. That is why, so that the patients can be referred for the specialist care to prevent and manage these serious complications. And at physician level, that investigations are recommended to diagnose as well the condition as well as to confirm for any coexisting other diseases or its complications. We shouldn't forget PCOS is the diagnosis of exclusion. That means once we have ruled out other causes of irregular menses or hirsutism, so baseline investigations, what we do at the diagnosis is the TSH, prolactin, and the third one is for to rule out any cause related to adrenal glands. So if all these things are in normal range, only then we should label it as PCOS. So just going to the basics, what do you mean by irregular menstrual cycle? No, it is irregular menses are normal in first 1 to 2 years in postpubertal age, but if after 1 year, 1 to 3 years post menarche, if cycles are up to 45 days, that is taken as normal. But in adults, if it is more than 35 days or less than 8 cycles per year, that is taken as irregular menstrual cycles. Or if 1 year post menarche, she is amenorrheic for continuously for 3 months, even in a single cycle, that is also taken as irregular menstrual cycle. And if she doesn't attain menarche by 15 years of age or 3 years post thelarche, Usually, within 3 years of breast development, menstruation starts. But when menstrual irregular cycles are present, then the diagnosis should be considered and we should assess according to the PCOS guidelines. So this is the history based. And another thing is hyperandrogenism, which is on examination, or otherwise patient might be giving the history of clinical hyperandrogenism in the form of acne, acanthosis, or hirsutism. So, at times we are unable to diagnose hirsutism because the local therapy has already been done. Patient says that I have done waxing or I have got done laser. I have taken 6 to 8 sittings of laser. Even then, my hair growth is not declining. So, in those cases, we have to consider that it could be a case of PCOS which has to be managed medically. And in physician's OPD, it is very easy to ask the patient to mark her this score for her hirsutism. Even you might not need to examine her. This is by the modified Ferriman-Galway score. Of if it is 4 to 6 or more, that is used as diagnosis for hirsutism. Or we can train our clinic staff, female staff, if we have, that might help in this case. So these are the sites at which if the hirsutism is unwanted hair growth is more, that is on the face as well as the back, front, thighs, arms. So if it is more than 4 to 6, then we label it as hirsutism. So these are the, for clinician, it is easy way to diagnose. Very simple way. If any two of the three conditions are present, if she comes to you with a menstrual or maternal complaints, or she has metabolic features, or she has mirror related means misfit masculinity, if any two of three condition of the three columns, any two conditions are present, we should suspect as PCOS and investigate on these lines. But we must remember, as we do for our other patients, we should pinpoint and prioritize her complaints and her concerns and challenges faced by her. Sometimes she is complaining of hirsutism, but her underlying concern is she is about to get married. How will she face her in laws? And her challenges are her parents are very conservative, don't allow her to go to parlor. So we should ask sympathetically, empathetically, so that she should open up and we should be able to help her out. And we should suspect and screen for complications, comorbid conditions like obesity, diabetes, hypertension, dyslipidemia, and concomitant missed therapies. In history, we must ask which type of treatments she has already taken. Sometimes they go for homeopathy, Ayurvedic, or some Ved, or some other Jhad Phook wala. So we should ask them. She might be, at times we have seen patients taking steroids from the village and she is presenting with such features. So we should ask that in detail also. So the management of PCOS is a collaborative team approach comprising of physicians, pediatricians, gynecologists. Obstetricians are also affected with this, and dermatologists. And moreover, if patient is depressed, she might be going to psychiatrist also. So this is a collaborative effort because its prevalence is so much that everyone needs to be very aware of it and how to manage it. And timely referral should be there. So of this, the counseling and patient education is centerpiece for the dealing with the patients of various age groups. And we can help them with medicines, nutritional supplements, diet, exercise, and specific tools and techniques for counseling. That is the basis of management of PCOS. So counseling is very important. That should be age specific. To young girl, adolescent girl coming to us, don't tell her if you don't take treatment, you might land up in endometrial carcinoma or you might land up in infertility. Please don't talk like this. So she might get scared and she will not like to lead her life normally. And if she is in reproductive age, we must ask whether she is planning pregnancy or she is not planning because medications depend upon that. And for menopausal and postmenopausal women, we have to give her dietary advice for weight control and exercises because the exercises for younger people and for elderly people are different because we want them to avoid fractures. So all these things are related to counseling of PCOS depending upon age. And above all, in the first step, psychological first aid. If someone comes to us and she complains of any of these features, we have to reassure this is a controllable condition. Although at heart we know this is not a curable, but if we lead healthy lifestyle, we follow the lifestyle modification, this remains under control. And pregnancy can often be successfully achieved either naturally or with assistance, because many of our patients in OPD come and ask, Doctor, will I be able to get married? Will I be able to conceive? So these questions are in mind of girls, even in girls of 18 to 20 years of age. So we have to tell them this is normal. And if they are obese and overweight, so sir, doctor, I am very obese. I don't know how will I lose weight, whether I will be able to lose weight or not. So we have to tell them this is most common association, but we have to work upon it. And the basic steps are diet, exercise, stress management, sleep hygiene, and screen time. In nowadays in our lifestyle, the screen time has very much increased. Maybe credit goes to the corona times, but we have incorporated into our lifestyle. Late time watching a screen, maybe in the form of mobile, laptop, or anything of that kind, and sleeping late, getting up late, so all cycle of our life is disturbed. So in lifestyle, we have to tell them healthy eating, regular physical activity. We should aim to achieve 5 to 10% weight loss. Even just 5% of weight loss is sufficient to induce ovulation and maintain regular menstrual cycles. We should assess them and monitor them time to time, how they are maintaining and how they are improving. We have to set goals for them, but it's better if they set their goals and we just modify them according to their needs. And goals should be specific, measurable, achievable, realistic, at a timely manner. Sometimes they say I will lose 2 kg, sometimes they say I will lose 4 kg in 1 month, and we have to tell them just if you lose 2 kg per month, that is also okay, and that is you will be able to maintain it. So we have to just modify their targets. And psychological factors play a very important role. So we have to elevate them, we have to help them elevate their mood, so that they should follow the lifestyle for a longer time. The best way is to follow lifestyle modification lifelong, which might or might not be possible with some of the patients, but we should encourage them. And we should tell them that they have to reduce dietary energy intake to induce weight loss. So, for that, the balanced dietary approach is important. That can be in the form of that ABC, it was just misprint. So, A is for Alu Arbi Anaj. In our plate, there should be just three compartments. One is for Alu Arbi Anaj, we keep it aside, and one is for one is for C, and one is D. B is beverages which are kept aside. D is for दूध, dahi, and dehi. Just to simply remember that doodh, dahi, and non-veg they can take. Means similarly, the other dal they can add to it. That means that they have to take the source of protein. And for C, it is for the fibers, fruits, all these things which increase the bulk in their diet, that has to be taken. And this is the food plate. If they take the smaller plate for their meal and divide it into three parts, take it 3 times a day, this is good enough to reduce their weight is reduced, their inches loss is at appropriate rate. So this can work well. And for the beverages, at times they follow all these things, but they take diet coke. Doctor, I am on diet coke because that helps reduce weight. They say it doesn't have any calories. So for those cases, we have to tell them best beverages water. And second best are you can take jaljeera, you can take lemonade, you can take lassi, whatever you want, the buttermilk, all these things you should take. But you should avoid aerated drinks or that pre-processed drinks, they should be avoided. And sometimes they say, I take protein shake. I have taken meal replacement with protein shake, but they just forget how many calories they are taking in it. So this education is to be given. This can be simply given by the doctor herself, herself or himself. So we have to tell them the meal composition should be like low glycemic index, low carbohydrate food, high in monounsaturated fatty acids, proteins, and fiber content. So they should aim for roughly 30% energy deficit in the form of 500 to 750 kilocalories per day if we take average of 22 kilocalories per kg. Then coming to exercise interventions, The all exercises give benefit if these are sustainable and according to one's preference and goals. Sometimes the person likes going to gym, but we tell them you go to yoga. You don't. Someone like aerobics, and we tell go for yoga. Someone likes walking, and we tell them you just sit around, or whatever the person's choices are there. We should suggest them to do that regular activity physically. Physically activity should be done, and that should be sustained and maintained, and try to increase the level of their exercise so that the results are better. And above all, the any physical activity is better than no activity. Even if you have to listen to a phone call, just move about. If you have to brush your teeth, just move about. So if you do some kind of physical activity in your day-to-day routine, that is better than just sitting like a couch potato. So which shouldn't be done. And for prevention of weight gain, 150 to 300 minutes of moderate intensity exercise or 75 to 150 minutes of vigorous intensity aerobic exercise, these help prevent weight gain. Muscle strengthening exercise should be done on 2 non-consecutive days per week. And for adolescents, the exercise level is almost doubled. Means they should do 1 hour exercise per day and with no off. If they do that physical activity and that kind of exercise with muscle training 3 times per week, they get better results in maintaining their bone health as well as to improve their muscle strength. So, if we suggest them the exercise regime, we should follow this sequence. First, we should go for the stability. If stability we have attained, then go for strength training, which improves the stamina, suppleness, and which definitely improves our smartness. So, first of all, we should go for flexibility enhancement, then balance training, then aerobic exercise, and last of all is resistance exercise. In our daily routine, initially start at this stepwise level, and later on we can increase the level of our resistance exercise. But always beware of safety, maintain hydration, motivation, as well as nutrition associated with vigorous exercises. So now coming to the pharmacological management, which physicians can do and physicians should be aware of. Uh, the first of all, we have done the uh, dietary modification as well as we have included the exercise regime. So what we can do medically, we can suggest them hormonal regulators like combined oral contraceptive pills, depending upon their requirement. These are usually given to the patients who are not planning pregnancy. We can give them metformin, anti-obesity drugs, depending upon presenting features, anti-androgens, inositols, and ovulation inducers can be given. So usually patients come with a menstrual irregularity. In these, if these are adolescent unmarried girls, usually we like to avoid the term oral contraceptive pills. At times, if we give them a strip of 21 tablets, then their parents say, "Oh, these are contraceptive pills. No, 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 my unmarried girl will not take it." What will my relatives say? That they will suspect her character. So I will not give it. So if we label it as these are menstrual regulators, this will help her get regular menses. So in those cases, a bit of counseling is needed. That can be given, and that gives very good results in management of hirsutism and irregular menstrual cycle. Try to give minimum dose of estrogen, like less than 30 microgram, and the routine combined oral contraceptive pills with any combination of progesterone can be given. But if hirsutism is too much and we need quick results, the best results are with the cyproterone acetate that contains the ethinyl estradiol of 35 microgram. So it's not mandatory to give this combination. This is kept as second line therapy over other COPCs. And progestin only pills, sometimes they say, I can't take 21 days pill or I can't take the 24 days pill. Then we can suggest them just take progestin for withdrawal. But and this is for withdrawal as well as for endometrial protection. But remember, this will not control the underlying pathology of hyperandrogenemia. And if she has some metabolic symptoms, then we can add metformin, which can be given alone, or with the if she has menstrual irregularity and BMI is more, then it can be added to COPCs with metformin can be given. So if she is in high risk ethnic group, is just like in Asian, if BMI is more than 25, because for Asian Indians, if BMI is more than 25, that is labeled as obese. But for other ethnic groups, if BMI is more than 30, only then we label it as obese. So in those cases, we can give it. And if she is presenting with hyperandrogenic features like hirsutism or severe acne, then the anti-androgens can be added to it. If alone COPCs are not working, even if these are given for 6 months, at that stage also the anti-androgens can be added to it. And if she is not worried about periods irregularity, then alone androgens can be given. And she should use other form of effective contraception. If she has contraindications of combined oral contraceptive pills, means if she is using IUCD, she is married using IUCD and hirsute, then alone anti-androgens can be given. And the milder form of medication, which is commonly used in India, that is inositols. And if she is not tolerant to metformin, these are also insulin sensitizers, and that can be given based upon individual's preference values, and it can be given. But if patient tolerates metformin and she is hirsute and central adiposity is there, then metformin is better. And sometimes patient has tried all methods discussed till now, means up to the metformin she has tried, but she is unable to lose weight, or she wants to lose weight fast. Then there is another group of medications in our armamentarium which is approved for treating obesity, that is GLP-1 agonist, that can be given, and these gives better result in the form of decreasing BMI and testosterone levels and improve ovulation rate in obese women with PCOS. But we should remember that while on GLP-1 agonist, we should give them contraception, because these are not studied. The studies have not been done. If the patient conceives with these medications, what will be the outcome? So she has to avoid pregnancy during while on treatment and 3 months after the treatment. And the another is the dual agonist, which helps in weight reduction and insulin sensitivity. In other countries, this is very much in use and giving very good results. And this helps a lot with weight reduction. And patients with those who have high, even insulin levels or uncontrolled diabetes with obesity with PCOS, they get very good results with this. So there are the now patient wants to plan pregnancy. So if such a patient comes to a physician and tells them that I want to plan pregnancy, so that is why if she doesn't offer her history, we should ask whether she is using any. She has any plans for planning for going for family way, or she wants to use contraception while she is on treatment. So if she is planning pregnancy, we have to change some of her medicines, because if she is having metabolic syndrome of these, if she has a hypertension, so usually we give them ACE inhibitors or angiotensin receptor blockers. But in such cases, we should prefer calcium channel blockers. For dyslipidemia, we should avoid statins, and we can prefer omega-3 fatty acids and dietary modification. If she has dysglycemia, so oral hypoglycemic agents except metformin should be avoided. And before planning pregnancy, it's better if she is on insulin for 3 months prior to planning pregnancy. And for weight management, we should select medication judiciously. If she is planning pregnancy and she wants to reduce weight, it's better to go for metformin. So when to refer to specialist? The patient should be referred to endocrinologist or a gynecologist. If on first visit we find she gives history of rapid or severe virilization, her testosterone levels are twice upper limit of normal range, in those cases it's better to refer to a specialist. Or we have given her first line measures for cycle control or androgen excess, these are ineffective. Or if comorbidities like severe obesity, diabetes, depression, obstructive sleep apnea, all other comorbidities are there, and we find that it's better to refer them to specialist, we should refer them, because for severe obesity, she might need surgery or she might like to go for medications, specialist medications. Or if patient has anovulatory infertility and she wants conception, so it's better to refer her to gynecologist or fertility specialist, because they can give her oral ovulation induction or injectable induction medications can be given, and follow up can be given properly to get the, because our primary concern is that primary concern is answered and comorbid conditions are well managed if we refer them timely. So basically, this is a transgenerational karma which is seen in modern generation, means our generation, what we are seeing today, our children and grandchildren who are coming. This is that if its cycle starts, if we prevent obesity and PCOS, later on preeclampsia in pregnancy, because these things are related. Those who are obese or those who have PCOS, they have more chances of getting preeclampsia, and during pregnancy they get GDM. If the GDM woman delivers and she is unable to control her blood glucose levels during pregnancy, so if that cycle starts, the infant born to the GDM, if a girl is born, she might be going with the PCOS, which may manifest when she becomes adolescent and adult later on in her life, or she, if male or female, any of the children, male child might get metabolic syndrome, and both of them are at risk of obesity and diabetes. So this is the that is our duty as a clinician to control this transgenerational cycle, or to have a good karma in it. If we educate, if we reduce the boj on dharti, means the, if we reduce the BMI, make it to the normal range, and we add to the society, the healthy generation is added to the society. That is the our good generational karma, which will be seen by after next generations. So as we know, the PCOS is a spectrum, multifactorial spectrum, need to be treated by multiple caretakers. So we should take it as a strength. All the branches of medicine coming together. This shouldn't be taken as a shortcoming. This should be taken as an opportunity to improve the health of future generations. So this is taken as opportunity rather than an obstacle in prevention of non-communicable diseases in our future generations to come. Thank you.
Thank you so much, ma'am. Thank you for your overwhelming talk that you have shared on our platform and for making our viewers understand about the topic in such a better manner. We hope that the information received by you would definitely be helpful for all the audience who have joined in today with us. Well, moving ahead with the question answers round, we have received few questions. So, the first question is related to the PCOS differentiation. So, how should physicians differentiate between PCOS from other endocrine disorders such as hypothyroidism, hyperprolactemia, and adrenal hyperplasia?
Yeah, because this is the condition, this is a diagnosis of exclusion. So we should test these three tests. Means TSH and prolactin level should be done. And for that the adrenal glands, we can get the DHES done. But that is usually not needed if she is not hirsutic. If hirsutism is too much or acne is severe, only those cases will need the adrenal test. So we will otherwise for every patient we will go for TSH and prolactin. If these are normal, then we will go for the PCOS.
Thank you so much, ma'am. Thank you for answering that question. Moving ahead with the other question, and the other question is related to the recommendation screening. So, what are the recommended screening tests for insulin resistance and metabolic syndrome in PCOS patients?
OGTT, oral glucose tolerance test. That is the simplest, which can be done at community level, and this is done at community level also in pregnant patients. This is for done for to rule out GDM, but that test can be simply done at any level. Taking the in fasting state, taking 75 gram of glucose, and after 2 hours we have to check blood glucose. If it is more than 140, uh, you had asked for which test? This for insulin resistance, na. So this is the
Yes,
test we can do if she is at risk, because if value is more than 140, that means she is in IGT range, so she has insulin resistance. Moreover, the clinically we can assess for features of insulin resistance, that can be in the form of acanthosis nigricans, that is the darkening of skin over neck, over armpit, over genitalia, all sides of genitalia, and that is the velvety dark skin is there. So that is the clinical feature of insulin resistance. And OGTT is the simple test. Otherwise, we can go for serum insulin levels, but these are costly tests, and practically and at mass level, this can't be done. And these don't add much of the value.
Thank you so much, ma'am. Thank you for answering that question. Moving ahead with the other question that we have received, and the question is related to the challenges. So, what are the challenges of diagnosing and imaging PCOS in adolescent patients?
Yes, so that is here the role of empathy comes, because the challenges are there if she is not PCOS and we label her PCOS. After we sometimes patient comes with the patient has some irregular menstrual cycle, and she is following strict dietary restrictions. I want to remain lean. She doesn't eat food because of low hormone levels. She is getting irregular periods, and somehow because of this hormonal imbalance she gets her ultrasound done. This is very common. Patient just go to the center and get it done, and the ultrasonologist writes PCOS, ovaries are bulky and rule out PCOS. So then she comes at doctor, I have PCOS. So these are the common situations. So we have to assess. We should follow the criteria. If it is there, only then we will label her. At times, if she is gaining weight, or if we get that kind of history of anorexia nervosa or any kind of dietary restriction, unhealthy dietary habits, we should tell her that you are at risk. You might get it later if you don't follow the healthy lifestyle. That is one scenario. And another scenario, if she is obese or if she is gaining rapid weight gain. So in those cases, we have to tell them. And if she is gaining weight, rapid weight gain is there. She is getting irregular periods, and she is adolescent, in which we don't like to go for, means up to 8 years of attaining menarche. Usually, we don't recommend ultrasound. In those cases, she doesn't have features of clinical hyperandrogenism. Means she doesn't have acne and she doesn't have unwanted hair growth. In those cases, we will confirm it with the lab test. That is a serum testosterone level. If it is on higher side, only then we will label her PCOS. It's not just left and right. We label every other girl who is coming with irregular menses as PCOS. So that we have to be very particular about it.
Thank you so much, ma'am. Thank you for answering that question. Moving ahead with the other question, and the question is related to the irregular periods. So, how should physicians manage irregular periods in signs of hyperandrogenism in adolescents?
See, for irregular menses, the if young adolescent is there, because if we see that her bony bones have not attained full maturity, in those cases, uh, we tell them, because I had in one of the slides I told, if she doesn't get her periods by 45 days, that is the criteria, that then we label it as irregular menses. In those cases, we can give them progesterone withdrawal. Initial stages, we can tell them to take progesterone withdrawal, that they medroxyprogesterone acetate 10 milligram twice daily for 5 days, then they get withdrawal. That is okay. But if we have examined her fully and we have come to know all her conditions and whether she can follow it or not, then we can put her on menstrual regulators, that is the hormonal pills. Minimum dose pills, the easily available. Otherwise, we can give them the government supply Mala N type medicines can be given. But if we want to give them very low dose, then there is one brand is the Dronis, means drosperinone added medications, estrogen plus drosperinone in 20 microgram. That doses can be given to her, and these don't add to their weight. Means sometimes the patient says, "Oh, no, no, doctor, I will take hormones, I will gain more weight." But these medicines help in reducing weight. It's because of these medicines, weight will not gain. That is one thing for sure. So that can be given to them on cyclic basis. She will take 24 days on and will take a break of 4 days. During that time, she will get her periods, and on 29th day, she will start new pack.
Thank you so much, ma'am. Thank you for
But this
answering
medicine
all.
will help her reduce for young adolescent. This medicine alone will help her reduce hyperandrogenism also. The hair growth will
Ma'am,
start
I think
reducing.
this. Ma'am, are you there? Hello?
Yes, hello.
Yes, yes. Your voice just got distorted a bit in between. But anyways, thank you so much, ma'am. Thank you for your valuable time and for answering so many questions of our viewers and for making them understand about the topic in such a better manner. I would like to thank all of our viewers as well for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. And I would like to thank you, ma'am, for taking out your valuable time and for being here at our platform. So thank you so much, ma'am. Thank you for your efforts and for your time. Before we
Thank you.
conclude, ma'am,
Thank
any
you.
last take home message from your end?
We should educate our family members because PCOS is not a disease of one person in a family. This is a disease of family. If we improve our dietary pattern, if we have to improve the health of family, the kitchen in charge should take charge that they will cook healthy food, and from the early childhood the healthy food means green leafy vegetable, dal, the cereals and home cooked food with the salads and fruit, this should be given to the child so that later on they are not fond of junk food. Means they shouldn't fall for prey to the junk food and make their health in bad shape. So the this starts from the kitchen and early childhood habits. If parents go for a walk, they do yoga, meditation, exercise, children will learn from just watching them. So that is my message. Children learn from seeing what their parents are doing, not what their parents are preaching to them. So that is for on the
Rightly said.
family and community level.
Thank you so much, ma'am. Thank you for your valuable message. And with your valuable message, we would like to conclude the session here for today. Until next time. And I would request all our viewers to look after themselves and to their family members and stay healthy. We will be seeing you all in our next upcoming episodes. Thank you so much. Thank you, everyone.
Okay. Thank you. Okay.